Welcome back, everyone. Up next, we have a lecture where Dr. Christina Franz ma'am will discuss circadian rhythm sleep disorders. This session will not only cover the physiological concepts but also assessment tools, non pharmacological interventions, and clinical cases to deepen our understanding.
Thank you. Welcome back. Well, this is our last lecture. We are coming to an end, and we are talking about something now that a lot of people approached me to ask. That is the circadian rhythm sleep wake disorders. But before we enter that, we need to understand, before we understand the disorders, we need to understand what is a normal, a healthy rhythm. So the circadian rhythm, get my pointer here again. The circadian rhythm is a 24-hour cycle of physical, mental, and behavioral changes that our body goes through. It's also known as our body internal clock. This started with some studies, I think back in 60s, 70s, about a plant who has an endogenous cycle. So the rhythm of these leaves here varied between 10 and 11 p.m., even when we were put in only a dark room. And this thing happened. So researchers started to see that was something else going on beyond the light and dark cycle. So circadian, the word circa means around days. So circadian, around days. What we have is a very, very strong photic information that comes through our eyes and signal to a multiple neuron circuits to the pineal gland. So this information comes here and signals to the pineal gland that will then release the melatonin. This stimulation of the pineal gland during the night, during the dark phase, will release the melatonin, that is one of the very important hormones of sleep. But again, this is not a hypnotic hormone, it's a hormone for circadian. So this melatonin goes into the circulation with broadcast a hormonal message in our entire body for darkness. The specific receptors for this melatonin hormone detect the circulating melatonin and complete this feedback loop from the pineal gland to the central nervous system. Oh, I forgot I did those things. We have a master clock that is a central clock. It's, of course, a metaphor that we have in our brains, but this master clock will regulate the melatonin secretion and also will regulate the core body temperature. So we see here in a 20-hour clock, what we see here is that when we have this increase in melatonin is about the dark phase is starting. So this melatonin increases and pick up in the middle of the night, you see here. And the body core temperature is completely the opposite. It goes down to a nadir, like we call, during the phase that melatonin peaks its highest levels. And then this melatonin starts to decrease while core body temperature starts to increase. And these are two features that are very, very important for making the sleep propensity, for making us sleep. So timing is another thing that is very, very important. We have here, I got this picture just to show you, because I need this to be very clear to you all, that besides the very important master clock that we have in our brains, this is a metaphor, we also have a lot of what we call peripheral clocks. And yes, our muscles, our skeletal muscles, are also peripheral clocks. So if we say that light is a very important entrainment factor, exercise, food, and temperature are also very important ones. I'm saying that having physical exercise and having a routine for physical exercise is as important as exposing yourself to light, okay, because of these peripheral clocks that we have in our body. All this information together with many of genetic ones that I'm not going to go through today here because it's not the focus, will have this circadian transcriptional rhythm, and this will make the rhythm in which we wake and sleep. So this is the very famous two-process model created by the group of Dr. Alexander Boberly. And here, what we see is that first, we have here the time of the day, so 6 a.m., 3 p.m., 10 p.m., and 3 a.m. Here we have what we call the homeostatic sleep drive. This is the sleep pressure. As long as we are awake, the pressure for sleep increases, okay? So if I wake up at 6 a.m. in the morning, I'm okay. And then as long as the day takes on, I'm going to feel more and more tired because of many reasons, but one of the reasons is the adenosine hormone that we spoke, I thought, on the second day. And this hormone is increasing during the day until it reaches a time here about 11 p.m. in this model that the subject goes to sleep to clear these products in the brain. Okay? The circadian drive is the opposite and is very dependent of our internal body clocks, the master one and all the peripheral ones that we have in our body. The circadian drive will also have the influence of the light and dark cycle, and these will also increase and have a slight decrease during the afternoon, starting increasing again until both process, you see the homeostatic and the circadian one, are combined with lowest temperature of our body, so we enter into what we call a behavior here, which is sleep. So this is the famous two-process model, and it's very important for us to understand it. I always forget that I put the animation things. So again, here it's the same that I showed before, just to show you that we have a measure that can be drawn in the blood and go to analysis, that is the LMO, dim light melatonin onset. So this is an objective measure. It has its rhythm, so it's quite hard to use that in research, but it's possible, and there are some guidelines for that for those ones who wanted to do research with that. So we have this dim light melatonin response curve that is possible to be traced, and we also have the CBT minimum, the nadir of the temperature that happens during the first time of the night. Uh, Dr. Zubia already spoke about you about being an early bird, which I am in Brazil, not here, and being a night owl, and about this chronotype that we can call one or another. But remember that we spoke, I guess, on the second day also, how important is to have a routine and to make everything properly at the same time, even on weekends. Okay, so it's no good if I have a routine during the weekdays and then on weekend I sleep until 3 in the afternoon and I go to sleep at 2 o'clock in the morning. So our body needs the routine to function properly. So it will understand what time hormone have to be produced, what time this hormone that produced has to be released, and things like that. So this information that comes outside from our environment is very important from the inside of our body. Okay, now that we know what are the circadian rhythms, how do we measure them before we enter into the disorders? We measure the circadian rhythms mainly by an objective examination that we call actigraphy. We have many actigraphs in the market. Here are only a few examples. I'm not using actigraphy on my daily practice just because I couldn't buy one until now. Uh, Maybe I will next year. But I used this for a few years in my PhD research. And we have many types of actigraphs on the market, ones that will measure only movement and the ones that will also measure the light exposition and the temperature of the skin. So what are the variables that actigraphy measures? It measures the total sleep time or sleep duration. It measures sleep onset latency. It measures sleep efficiency and measures the wake after sleep onset. So all of these variables, we have them in the report of the actigraphy. This is an actogram, how the thing is written. So this actogram is created when an activity is charted for 24 hours in a single strip chart. So what we have here is noon, midnight, and noon. And here we have the sleep period. These lines represent movement. So actigraphy will it will write down the movement of our body. And when we rest, it will infer sleep. Okay? So here we see that this subject is very active because it's moving, it's making movements. And we use the actigraph just like a watch. Normally on the left hand, when you write with the right hand, you use in the opposite. But when you write with the left hand, we use in the opposite. In children, because they will take it off, we use on the ankle. Okay, and sometimes we have some actigraphs that can be used as an thoracic belt. There are some actigraphs going on that we can use like fingertips. So here we see that this subject was very active and then slept. We see some little movements during the night and then he wakes up and goes to movement again. So first question that I have for you is, does actigraphy measures sleep? Speak louder, please. Yes, it gives all the sleep variables, but does it measure sleep? No. Okay, it doesn't measure sleep. It infers sleep by movement and rest. So we think that this subject was here sleeping, but it could be in a very quiet position without moving and completely awake. So the only measure that we have for sleep is when we have the electrodes placed on the scalp, and then we can see the brain waves. And reading the brain waves, we can see sleep. So actigraphy is very used in research because it's easy and it's feasible and it's very cheaper compared to polysomnography. But again, it infers sleep. So this is from my PhD, and what you see here is the control group and the insomnia group. This is good because you're starting to learn a little bit of Portuguese also, controle and insomnia. And what we have here in these green bars, we have the sleep time. These pink ones here, you see, is the time that the subject takes the wrist off for bath, for swimming. The actigraphs are, many of them are waterproof, but we are afraid of what the volunteers can do. So we ask them to take it out while in the water or having water contact and put them on. So you see here, we have a blue marker, and we ask them to do the actigraph together with the sleep diary that they are feeling all the time. So they will mark on the sleep diary the time that we take it off, and then mark again the time that we put it on. It will help when we read the exam. So what we see here, we see a routine. I mean, does this patient, each line of this is one day, one completely day, okay? So here I have 1, 2, 3, 4, 5, 6, 7, 8, 9 complete days and nights, okay? Does this subject has routine about the same time of going to bed and about the same time of waking up? Yes, okay? It goes to bed about the same time. Here we have the time. I know it's too small. Here is the going to bed time, and here is the waking up time. If we compare these with this insomnia patient that I have, what we can see is that nap here during the day. One day is go to sleep at this time and the other one earlier than later. So we don't see a routine here. And also what we see is that sleep is very fragmented here. So we have lots of movements, a huge movement here. And we cannot see this right here, but while we are reading the actograms and the result sheets, we can see the amplitude of the movement. And there is a certain amount that is considerable for movement. So if we see that, we mark as a movement. So these ones are the ones that I read for my PhD. But I found that this particular patient here had something very, very interesting. In Brazil, we are used to take baths every day, sometimes twice a day because it's hot. It's a hot country. And you see that this patient didn't take it off. So she was not having bath every day. Yeah. So I talked, what's going on? Is something going on? Do you need any help or anything? And she was having bath with the actigraph, okay, in this case. So this is a measure that we can, the polysomnography will take just one night. We will have the picture of just one night. In actigraphy, we can have a picture of 1 month of 1 year. There are some studies that have 5 years of subjects having this activity. So you really have a pattern in a long time. This is really interesting. Here you see a 78-year-old female, and what you see here is that in this actogram, that is this figure of these 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 15-day actigraphy. What we see is a consistent time of sleeping and going to bed. So we look for the rest intervals here, start time and ending time. We see that this is this patient here had a routine. But this one, you see how different those things are? This one is like that last one that I showed you. So each day is go to sleep in a time and wakes up in another time. So we see that this one doesn't have a routine. So the first thing we have to try to understand is why. What's going on that this subject does not have a routine? Is it a behavioral thing, or is it a disorder that needs another kind of treatment? Other thing that is very, very important is the actigraphy must be taken at least for 10 to 14 days. But you should have your patients performing actigraphy during the weekdays and the weekend, so you can see if there is any change. Sometimes we have some research or some people that ask patients to use only for 3 days. That doesn't give you much information, 3 days, because the routine, the complete routine, can be one during the weekdays because of professional issues and completely different in the weekends. So take at least a minimum of 10 days to evaluate your patients. In research, we usually say 14 days. So this is another kind, and as you see, the black lines are the movements. These blue squares here, we have sleep. And in this one, you see the yellow lines. The yellow means the light that the device is getting. So it has also an amount of how much light this gets. This is very interesting for some types of research. We have a print report, just like in PSG, with all the variables that we can read. And this I brought to you because this was the result of my 6-year PhD. 6 year to this one here. Like, you are all researchers, so you know what I'm speaking about. And here we have, I'm not going to speak about the project itself, but just for you to see that I had 4 groups of postmenopausal women with, we studied, this is the control group, so you can see a routine. This is the chronic musculoskeletal pain group. You see it slightly different from this one here. And also here we have the insomnia group. So the picture looks like a lot like this one here. And here we have the group with both comorbidities, both with insomnia and chronic musculoskeletal pain. So we compared these actigraphy data in the examination. Okay, now that you know what is a circadian rhythm and how we measure them, these are some of the evaluations that we can have. We can have many others like cortisol curve and other biomarkers, okay? Let's talk a little bit about the disorders. So the circadian rhythm disorders, I usually say, is when one of these athletes misses the perfect timing. So you see, these ones here, they missed. So this would be a circadian disorder. These are caused by alterations in the circadian timekeeping system, its entrainment mechanisms, or a misalignment of the endogenous circadian rhythm with the external environment. So you all know I am suffering right now the effects of a circadian disorder, because for me it's exactly 3:42 in the morning, so I should be entering my second REM sleep stage. My brain for sure is trying to make some slow wave sleeps, and I have to be here with all these lights coming to my eyes, informing my brain that, Chris, you are in India, so this is daytime, it's midday, you are having lunch just right now. So the hardest thing that I find here is not to be awake, it's to eat when I get up. Because when I get up in the morning, I speak to my husband and to my son, and they are going to bed. And my son says, "Oh, mommy, good night." I say, "Good morning." And I have to eat, and I can't. I just keep chewing, and I can't eat because I have no desire to eat at all. So this is the thing that I find most trouble. But back to here, the circadian disorders are when we have normal sleep quantity and quality, but with an undesirable time. So this timing means a lot. It can happen because of change in light and dark cycle in relation to my internal clock. So I can have a internal clock disorder. It can happens regarding the environment, just like me right now, and I can have a dysfunction in this whole clock mechanism. So one of the dysfunctions might be, for example, lack of melatonin, okay? Or any vitamins that will precede melatonin, for example. We have, as all the sleep disorders, we have a criteria from the International Classification of Sleep Disorders. And these three items must be met. So we have a chronic or recurrent pattern of sleep-wake disruption due to an alteration of the endogenous circadian time system. Or we can we need to have a circadian disruption that will lead to insomnia, excessive daytime sleepiness, or both. I am having both, of course. So when it's time to sleep here, you all go to sleep, and I go like, oh my God, I need to sleep. I have a course tomorrow. I want to go to the busiest market I went in my whole life, and I had all my concept of chaos defined again yesterday, and I can't sleep because it's afternoon for me. I'm not used to sleep during the afternoon. And so I have insomnia symptoms. And during the morning, I'm so sleepless. So both can occur. And the sleep and awake disturbance cause impaired during the day. So it causes headache, it causes an influence on the job I am performing, it influences my relationships. So it needs to have a functional impairment, okay, to be a circadian disorder. So it's what I told you, normal sleep, but at an undesirable time. We have some change in the light-dark cycle in relation to this internal clock. These changes are related to the 24. I think I had these all already. I'm sorry. The circadian disorders can be both from intrinsic, generated by endogenous mechanisms, and extrinsic. So we are going to go through both of them right now. The intrinsic ones, we have all these 4 disorders here. They are generated inside. And the extrinsic ones, they will depend of the environment. So shift work disorder and the jet lag. Let's go first at these intrinsic ones. What we see here is a typical sleep phase. So here we have the clock from 4 o'clock in the afternoon until 4 o'clock the next day. And here in this gray bar, we see the sleep time from midnight until 8 in the morning for this subject here, for example. When we have an advanced phase, the subject should be sleeping here, okay? But it has an advanced phase. It comes prior to sleep time. So instead of going to sleep midnight, this person needs, you remember the homeostatic process and the circadian process. When they meet, for this person, this happens and the core body temperature is at its lowest. Melatonin is shifted also. So all these happen in advanced phase. Okay? We have the delayed phase. So this one here should be sleeping at midnight, but goes to sleep at 4 o'clock in the morning. And should awake, for example, at 8 in the morning, but it wakes up at midday. So I'm quite sure you are remembering friends and sons, daughters, and people that you know that might like to go until midday sleeping. There are other one called irregular sleep-wake pattern. As you see, all the time we have these black squares here. The subject is sleeping. So doesn't have any routine. It can sleep at any time. We just talked about a patient just before this lecture that we have irregular wake-up pattern. And finally, these 3 last bar here represent a non-24-hour sleep pattern. That means that this is in free running. Each day it delays a little bit more. So it's like saying that the day for these ones here doesn't have 24 hours, but have 24.5 hours today, 25 hours tomorrow, 26 hours, and then the next day, and next week, the day might have 27, 30 hours. So it's delaying each day a little bit more. Okay, so how do we treat and how do we see each one of them? Delayed sleep-wake phase disorder. So here we have the normal sleep, and this sleep is delayed. It's a significant delay in phase of sleep-wake cycle in relation to desired or required sleep time and wake-up time. Symptoms must be present to be considered chronic at least for 3 months. And sleeping ad libitum, that means as the subject wants, leads to improvement in sleep quality and sleep duration and maintain a delayed phase pattern. And of course, not explained for other disease. So it's very, very common in adolescents. Okay, I have a 14-year-old boy, and at the weekends, during the weekdays, he has routine because of school. But during the weekend, if I let, he will sleep at 2 in the morning and wakes up at 1 in the afternoon. So I have to, everyone who has an adolescent at home will need knows this. So we need to wake them up and set the proper time. This is the hardest thing to do with them. So it's kind of a normal thing for this age phase, and we were all like that when we were adolescents, okay? And it changes a little bit again when we are adult, and it's going to change again when we are elderly ones. We are just going to go through that. It's more common in adolescents. The prevalence is about 7 to 16%, and there is an estimation that it occurs in about 10% of patients presenting to sleep clinics. There is no gender differences, and the positive family history for about 40%. We don't know exactly the causes, but mechanisms can include behavioral factors, psychological ones, genetic involvement, and some alterations in the homeostatic regulation of sleep. The behavioral preferences, they like late evening homework, TV, internet things. They use caffeine to combat sleepiness during the day. They have undesired bedtime and rise time, abnormal relation to his sleep homeostasis, and the ambient has a lot of artificial light during the night, and they have a delayed exposure to bright light in the morning. So this is something that is very, very common in these younger people. The psychological change that we are having are the alterations, of course, in the system, the circadian system, persistent delay despite this sleep-wake time enforcement, hypersensitivity to bright light melatonin suppression, reduced sensitivity to photic entrainment, and prolonged free running period length. We may also have some genetic polymorphisms on the clock gene, PER3 gene, and altered homeostatic regulation in these patients. Usually, if we have the sleep diary together with the actigraphy, we see that sleep onset is sometime between 1 and 6 in the morning, and the sleep ends between 10 and 3 o'clock in the afternoon. In the weeks, this is my son. Weekdays, no change. Weekends, this delayed pattern manifests. So sometimes it's difficult to see in daily routine. And my friends that work daily with actigraphy, they like to ask their patients to have the actigraphy examination during holidays, because then they are free to sleep and wake and see the real pattern. In polysomnography, the evidence that we have for this delayed sleep-wake phase disorder is that they have, when in habitual time, they have normal sleep, but when they are in control time, like in social time, in weekdays, okay, they have increased sleep latency and decreased sleep duration because they are sleep deprived somehow. The temperature, the core body temperature has a delayed nadir, and the same stands for the melatonin secretion. And I'm sure you've gone through the Horn and Osterberg questionnaire with Professor Zubia. They have a tendency to be the evening type person. The actogram of this disorder will look like this. Here is 6 a.m. and here is midnight. So here is something about 4:30 in the morning. So we see that this patient sleeps 4, 5, even almost 6 in the morning. See how short was this sleep here. So very, very restrict. Okay, and trying to compensate in the other days. Look at this day here. Went to sleep about 3 o'clock in the morning, slept until the next day about 2 o'clock in the afternoon. See? So if we have a long time of this actigraphy going on, each line is a day. So here we have more than 60 days. We see that we have these alterations here. Okay, so it is how it will look like in the actogram. And then the patient comes like this, have an evaluation, has a chronotherapy, and then it stabilizes. So our aim is this, to maintain a routine and to teach them how to maintain a routine. Oh, I don't have an actigraphy. Can I do that only with the sleep diary? Yes, we can. So we send the sleep diary at home and ask the patient to fill it out. So having everything together for this delayed sleep-wake phase disorder, the treatment consists of dim light melatonin onset, but we are physiotherapists, we don't work with melatonin because it's a hormone. So how can we treat this patient? We can use cues for the bright, for the light and dark cycles. So I can instruct this patient to wear dark goggles, okay? The white lenses, just normal dark goggles from 4 o'clock in the afternoon until it reached the night. But we can also wear bright light therapy, and here it's not getting any light and starting to wear it. We need a proper wavelength of the light. We need a proper amount that we call lux. So about 2000 and 2500 lux for 2 or 3 hours, starting from 6 a.m. here. Okay, so we can use this bright light therapy. As we can see here, the melatonin is at here we have the normal sleep phase. So melatonin should be here, and it's completely delayed in this patient. Same thing happens for this core body temperature. So if I have a delayed phase, what should I do with this patient? I should bring it, I should advance it. So I'm doing it using bright light therapy. Okay, so I'm going to show that to you. This is the glass that I use. So this is one of the things that we have in the market. We also have some light boxes that the patient, it will just look like my computer. The patient can just sit in front of it and turn it on and then have breakfast, read a paper or something. But the thing that I found hard with this box device is that I have to stay in front of it. So I like these glasses that are from Australia, from the group of Professor Danny Eckert, that is very a famous group of research for obstructive and central sleep apnea, but they are also investigating circadian rhythms disorder. So I'm going to show that to you. You all going to handle it. So what we have here inside is a button that we press, and a blue light will turn on here. Oh, Chris, but this is not a blue light. I see green. Yeah, we see green, but this is blue. Okay, trust me. And then if I press the button, I have two intensities. But our eyes, you see the difference? No, we can't, because our eyes can't see the difference of the intensity. So I hang it on like this in the morning here. So those ones who came to my room in the morning to pick me up here saw me like this. So I stay every day here for 1 hour using this bright light. I don't find it very comfortable. When I look to you, okay, but if I have to look down, my eyes goes to this thing, so I find it a little bit annoying. So please hand this carefully and try yourselves on, so everyone will have a look at it. Does anyone here makes research on circadian rhythm disorders than you? Anyone else? No, just her? Okay. So try it on, try the light, see if you can handle it. Now we are talking about the opposite one that is less common, but it's called advanced sleep wake disorder. In this disorder, the sleep and the wake up times are usually earlier than society requires. We have an involuntary early morning awakening, so the subject just wakes up in the middle of the night between 2 to 5 a.m. The prevalence is unknown and there is, as I said, less frequently than the other one. The mechanisms include abnormal phase response light curve, altered exposure to entraining factors like light, physical activity, meals. Okay, meal is another very important entraining factor. You may also have a familial inheritance, polymorphisms in the PER2 gene or in this other one, and it's very common in preterm infants with low birth at weight. We have that in elderly ones, so this is the other end that we spoke before. So I have many patients that complain, patients with apnea, and they say, oh, I wake up 3 a.m. in the morning and I can't get back to sleep. So this is a difficulty in staying awake until desired time, and they are unable to remain asleep until the desired time for more than 3 months. Of course, there is an impairment in function, and there are also non-age related advanced sleep wake phase disorders believed to be very, very rare. The prevalence tends to increase as we grow old and is estimated to be about 1%, so kind of rare. How the sleep diary and the actigraphy shows us. The sleep onset is about 6 in the evening to 9 in the evening. The sleep ends in the middle of the night, and as prior in the weekdays we have no known change, and the weekends we have the pattern presenting itself. In the polysomnography we have reduced sleep latency, reduced REM sleep latency, and reduced sleep duration, both showing the sleep restriction and the sleep deprivation that this patient has. The temperature and melatonin will have an advanced lowest temperature, and melatonin will have a secretion, advanced secretion also. And in these patients, the Horner-Osterberg questionnaire will show a morning type patient. So here again, we have the normal sleep phase and the normal time of the melatonin and the lowest core body temperature. And in here, we have the lowest core body temperature that is advanced. Sorry, here is advanced. And here we have the melatonin onset that it's also advanced. So what we have to do with this patient is this yellow arrow. We have to delay it a little bit. So we use the light here during the night. Okay, so um, we use here in the night, and we can also in the afternoon, if we have bright light, we can use some dark goggles. So evening bright light therapy is usually about 2500 lux for about 4 hours starting at 8, or 4000 lux for 2-3 hours starting from 8 to 9 hours. So it's a long time to be exposed in these bright light devices. And in case of melatonin, it should have here, in this case, a morning administration. Okay. The irregular sleep-wake pattern, as we see here, no routine is present. We will have an absence of well-defined circadian rhythm sleep-wake cycle, typically more than 3 sleep periods with variable length. The total sleep time, when summed, it should be normal, but the timing that sleep happens is not. It can lead to insomnia or excessive daytime sleepiness, and the prevalence is unknown and associated with some neurological disorders, like brain injury or neurodevelopmental disorders or dementia. It's really burdensome on caretakers. The sleep diary and the actigraphy will show an irregular pattern and multiple sleep periods both during the day and during the night. The PSG will also show this irregular pattern, and the sleep may be normal with the age range. The temperature and the melatonin goes completely crazy because of the pattern, and we have no idea if this is a morning type, an evening type, or an indifferent type of person. This is a dysfunctional of central processing that generates this rhythm, and the reduced exposure to bright light and those social shadows also play an important role. For example, institutionalized patients, they can develop this disorder. So the treatment is morning bright light and daytime bright light exposure for children and adults with dementia. Treatment is mainly light and melatonin, okay? So we can also use physical activity as a form to give the cue of timing at the same time every day for these patients. And of course, minimize light and noise exposure during the night. I think this irregular is the most difficult one um, to treat and to see in practice. This non-24-hour sleep pattern is the last one from the intrinsic ones, and this is when the circadian pacemaker has no stable phase in relation to the 24-hour light and dark cycle. It's common in blind people, okay, because they don't have the input, the light input, as though they can see a little bit, they can, it depends on what kind of blindness they have, but they can feel the light, but they cannot have the information coming through the eyes. So it's often in blind individuals, and up to 50% of these totally blind subjects that doesn't have this input, the circadian clock free runs with a rhythm that is slightly different from 24, coming to each day a little bit more. So you will also find the name of this disease as free running type or non-entrained type or non-24 hour sleep wake disorder. It is because of a reduced or absent of the entraining effects of the light. They don't have the follicles that are insufficient to entrain their circadian rhythms, and the melatonin rhythm may be non-existent or may be very, very delayed. In the sleep diary and activity, we have this unstable pattern and delayed each day a little bit more. In the polysomnographic, we will have also this unstable pattern, and the sleep duration may be normal, but the timing that this sleep occurs is not. Both temperature and melatonin are progressively delayed, and we don't know if they are early birds or night owls. So this is in blue, we see the sleep time, and we see that each day it happens a little bit delayed. So it will look like this or that each day. Okay? In the sleep diary, we will also see the same pattern going on. The treatment is bright light therapy, morning activities, avoiding evening light with blue blocking glasses, and consists of wake promoting or sleep promoting medications to help with the symptoms that this inconsistent timing of sleep happens. Okay? And beta blockers to inhibit morning melatonin secretion. We also have the two final ones that are the extrinsic ones. Well, the jet lag thing, as we talked about. So this is me coming to here, and we have the external environment being temporarily altered in relation to the timing of the endogenous circadian rhythm by quickly traveling across the time zones. The severity of this misalignment depends on how many time zones we've been crossing, and depends if you are going east or west. Okay? So I'm not really worried about it. It is bothersome, but soon as I get back home, everything will normalize. But I know this, okay? Sometimes patients they just doesn't know. We were discussing prior to this class that I had a lot of stomach aches when I got here in your country. That could be because of food, but that could also be because of the jet lag, okay? I think it's both. So we have this misalignment of the biological and the social timing that happens in the jet lag. Some say that it's easier to adjust when you come from India and go to Brazil to visit me. But others say it's harder to adjust when it comes to from Brazil to India. So I'll tell you later which one I found most trouble. This is the first time in my life that I have this jet lag thing. I've been to Africa, I've been to Europe, and I never had it, never suffered from it. So everyone was telling me about the jet lag, and I was going, okay, I never suffered from it. I'm not going to suffer again. So this jet lag causes daytime fatigue And sleepiness, nighttime insomnia, a lot of mood change, difficulty in concentration. Oh my God. Professor Zubia asked me yesterday to write some things, and I was like, oh my God, how am I going to write it? It took me hours to get the thing written because of this difficulty concentration and a general malaise. So these symptoms all they would resolve when we get back home. For eastward travelers should avoid bright light in early morning, but that again depends on where you are and how much time you are away from your home time. So it depends. But what I try to do is increase exposure to bright light in the morning and in the evening. So I try to be with the dark and light cycle. So I have the curtains open. When it's day, I see the light. When it's night, I see that it's dark. This will help me to entrain. Not talking about this. So the treatment is bright light therapy and combined light with some strategies to improve sleep. So a lot of behavior strategies need to be together here. We also need to combine these exercises with light. Outdoor activity, avoiding evening light with blue blocking glasses could be a solution, but there is limited evidence. And following appropriate time schedules of light exposure and avoidance before, during, and after flight to reduce this misalignment should reduce jet lag. When I talked to my physician that I was coming to India, she gave me a set of rules to do in Brazil prior to come here. But to be honest with you, it's very hard to make them because I was working until the day I traveled. So I could not adjust the things that she told me in my agenda to come here. Maybe I would have suffered less. And minimizing environment and individual stressors before, during, and after travel could help reducing this fatigue associated with jet lag. And the last of these circadian disorders is the shift work that we call the social jet lag. So this is a desynchronization of the circadian rhythms origination from the disorder between the preference of school schedules and the social or professional obligations that we have because of work, school, childcare, and other responsibilities. So the criteria from the International Classification of Sleep Disorders, there must be a report or insomnia or excessive daytime sleepiness together with a reduction of total sleep time. The symptoms they might be present and associated with the shift work schedule for at least 3 months. We might have a diary or a sleep log, or, if possible, an actigraphy monitoring for at least 14 days. Okay, needs to cover the work days and the free days, and this all this disturbance is not explained by any other diseases. So we have different kinds of shift work agendas, and the shift works get worse when we have like an irregular schedule. So we have evening shifts, night shifts, early morning shifts. These are all bad, but they are even okay. Rotating shifts and split shifts, on call shifts, they are the worst. because the body will never know when it's day, when it's night, when it gets to sleep. You see, the craziest thing is that these professions are very important. So this is an airplane pilot that has many lives in his hand. This is a physician. This is a physiotherapist that goes into emergency care during the night. So we need and we learn how to be very alert and to be uh, with everything in our minds working during the night shifts. So these are the worst ones. And they all include some kind of sleep deficit, increase of accidents, mistakes, and other adverse health outcomes, just like gastrointestinal, cardiovascular, and psychosocial disorders. And there are increased risk for other sleep disorders. So the shift work is when the worker cannot rest properly after the shift and cannot participate properly in social activities. But yet, we need them for our society to work. So it's kind of very complicated and has many social and cultural aspects. This is a actogram from a shift worker. So in blue, you see the sleep, and in dark here lines, you see the movement. So we see that it has no rhythm at all. Now take a big breath. We are coming to an end, and we have some very quickly clinical cases that I am not resolving them. This time you are resolving them. Okay? So first, we have a 20 years of age with difficulty falling asleep. Can someone please read the case for me? Can you please? Uh, do you think it's better to get the microphone? So everyone will listen.
Woman, 20 years old, complained difficulty initiating sleep, inability to wake up at 8 a.m., problem present for 2 years. During the week, goes to bed at 11 p.m. but only sleeps at 2 or 3 a.m. Alarm, wakes up at 6:30 a.m. Tiredness, EDS, weekends, wakes up at 11 a.m. Rested without complaints. No fragment sleep. Because of the difficulty sleeping, she reports drinking alcoholic beverages or off label medication but feels nauseous in the morning.
Thank you. EDS stands for excessive daytime sleepiness. Okay, I should have written it. So, this is a 20-year-old woman, and this is the sleep diary. So, as we see here, Sunday, Monday, each line we have a day. The arrow pointing down means that she was at bed. The X means the lights out, and this line means sleep. So you have this legenda here. And this is the time that she got out of the bed. So we see how much she thinks that she was sleeping. Okay? So having back again so you can remember, you see that she goes to bed at 11 but only gets to sleep at 2 or 3 a.m. and wakes up very, very early with the alarm clock. Having said all that, what kind of circadian rhythm do you think this could be? Back again? You want me to come back? Okay, let's see that again. She goes to bed at 11, but only sleeps at 2 or 3. Yeah, perfect. Delayed sleep-wake phase disorder. Great. What suggest would you tell her? What treatment would you suggest to her? Okay, speak it louder, please. If she can get the microphone. Come on, don't be ashamed. What time you should tell her to wear these fancy goggles?
Bright light therapy.
I don't hear.
Bright light therapy.
Yeah, but at what time?
Morning.
So she has delayed sleep-wake
Morning.
phase disorder. What's your aim?
Early sleep. Early
You
sleep.
need to normalize the week. So if the sleep is delayed, you have to, yes, perfect. So you use that in the morning, right? Perfect, thank you. Now we have a 60-year-old man with early morning awakening. This is very common in my practice. Can you read that loud, please? Get the microphone, please.
Irritability in waking up at 4 to 4:30 a.m. without being able to sleep afterwards. Recently retired, woke up very early due to work. He was unsuccessful when trying to adjust to his wife's routine, that is from 11 p.m. to 6:30 a.m. Denies depressive symptoms, denies snoring, stay in bed until morning but feel irritated, naps during the day.
Okay. Now let's have a look at the sleep diary. So what we see here is
Fixed pattern.
yes, naps during the day, yes, and coming back so you can remember. So he's having difficulty staying awake after 8, and he has been crazy and irritable in waking up at 4 a.m. and cannot sleep again. So, what do you think is going on with this man? Yeah, perfect. Advanced sleep wake phase disorder. What treatment should you suggest to him? Bright light, only bright light. Can we think about something else that could maybe help?
I was about to ask you that in advanced sleep wake phases that are going to sleep earlier, can't we start doing the any type of the moderate to high intensity exercise late in the evening so that it can shift it?
Yes, perfect. I was going to, I was hoping this answer would come true. Exercise is a very important time cue. It will inform our body about the time. So we have to increase the research about exercise for sleep disorders, but also for circadian ones. Okay, there is a group doing it in the US, but they don't have physiotherapists in the group. Okay, they are physiologists and things like that. And this is the thing that we know most because this is us. So we must um, go for research in this area. So exercise, perfect exercise, having a consistent exercise every day at the proper time will help these patients. Okay, it's not so the patients will not have the same property that has light. Okay, light is the main one, but exercise is much important too. Okay, so the third one is the sleep older woman that hates routine. Iron, please. Alzheimer's disease.
Complaint, EDS, sedentary lifestyle, waking up confused, noisy, and disoriented during the night. Donepezil, 10 mg per night sometimes.
Yeah, she's on these pills to sleep. So, what gets your attention here? Elderly patient, Alzheimer's disease, long-term institution. So here we see we don't see, we see the actogram, but we don't see anything in here. We see, I'm not telling what we see. So remember this one. What do you think is going on with this? What? Perfect. She has irregular sleep. What kind of treatment can be performed?
Exercising routine.
Exercise routine, any kind of routine. Exercise, meal routine, bright light therapy, and socializing, having the curtains open. Every cues must be given to this patient. And also behavioral guidance. Maybe not to the patient, but to, yes, perfect, perfect. That's it. And I think this is the last one. This is a patient with insomnia and EDS. So someone at the back, please, can you read it for me? Somewhere here in the back.
Female of 30 years old, bilateral enucleation of the eyes due to trauma, adjusted to the condition but has difficulties with routine. Complaints of sleep well in some phases, but in other experience periods of insomnia at night and excessive daytime sleeping during the day for long phases or months, and has noticed a repetition of this pattern since the accident, alternating periods of good sleep and very poor sleep.
So here we have a very specific case due to trauma. And we see the actogram goes on like this. So what we see is that sleep is shifting, delaying each day a little bit more. What kind of sleep disorder would you suspect? Yes, it's easy, isn't it? Non-24-hour sleep. And what kind of treatment? Can it be the same treatment for irregular that we just spoke before? Yeah? Okay. That's it. So here I have for you, so you want to take pictures. Everything grouped together, okay? This is the last slide. What we have here first is a free learning, so the non-24-hour period. This is a normal individual, so here I have some examples. This is a phase advance that we can have in these disorders, and then again synchronize it. Here we can have some old age endogenous depression that can have this phase advance, and here the phase delay. So we will have all these coming to seek help from us. So as all the lectures that we have lots of reading material on that too. And with that, I finish this lecture. Okay, thank you. You're very welcome. So first, I want to do something that I do every time I go. I want to take a picture of everyone over there, a selfie. Is it okay? Yeah, okay. Yes, please. Okay. Okay, I'm not expert in melatonin, but I'll try. Yes. Yes. Yeah, it depends on the whole thing. And melatonin is not so easy as we see or as everyone talks about, because it also depends on how much do you take. It not depends only on the time that you take, but of how much do you take. So many researchers have been doing um, research on that, trying to look for optimal quantities of melatonin for each kilogram, for example. And for each of the disorders, they will have a proper time, but it will depend on what time do you want. So if you have a delayed disorder, at what time do you want to shift that? So if it's to 9 o'clock or 10 o'clock or 11 o'clock, the time that you are given the melatonin will also change. So there is no one specific time for everyone. It will depend on what are your aims for that specific patient. So this is something that I find very interesting in sleep science and the sleep physiotherapy, because treatment is completely individualized. Each patient will get something. But in the other side, this makes research very, very hard because it varies a lot. Okay, thank you. The bright light. Yeah, sure. Yes, it will delay your sleep as soon as you are exposed to it. So the best thing to do is when we enter late evening, like when the sun goes down, we should shut off this kind of light and turn on just the yellow ones, dim light, yeah, dim light. So this is something that we can do in our houses, and I do in my house. We only have dim light when it's dark, okay, because it will interfere within the melatonin and therefore with the sleep quality and quantity. Okay, you're welcome.
Actigraphy measuring sleep onset latency.
How is actually
Actigraphy measuring sleep onset latency.
actigraphy is not really measuring sleep. Actigraphy is not able to measure sleep, because to measure sleep, we need to have the electrodes placed on the skull to see the brain waves. So we say that actigraphy infers sleep by, and then this is the answer to your question, by the movement of the body. So when the body is movement, I know that that person is active. And when I have no movement or very less movement in amplitude that we can see in the movements of the actogram, we can infer that that subject was sleeping. So we say that actigraphy examination will infer sleep time and waking time. But if I want to know, for example, in which sleep stage the subject of my research is, I need to perform a polysomnography. I'm not going to be able to see that in the actigraphy. So actigraphy in research is usually used for large populations, long follow-up, okay, and just try to understand a pattern of the circadian rhythm without measuring sleep. Sometimes we will see some research that we will have both actigraphy and polysomnography. Okay?
But actually, as you mentioned, that it usually gives us some information about total sleep time and wake after the sleep onset and sleep onset basics and everything. So, is it really giving us any particular data about blue light?
Yes, it does. But again, you cannot say specifically that that was sleep. Okay? But you can say that, for example, that group that you studied with actigraphy took about 40 minutes to go to sleep because you can measure that. Okay, so you will have this as an answer from the actigraph report. Uh, when we there's a lot of studies that compared actigraphy variables with polysomnography variables to see if they match, okay? And they had a pretty good reliability. So that's why we use actigraphy as well, okay? You're welcome. I think I have some of these comparable studies in the material of polysomnography, okay? I think I added two studies specifically about this, so you might want to have a look.
Is the blue light in the glasses different from the blue light that is emitted from our smartphones? Like it is said that
Yes, they are. Yes, they are. They are different in the wavelength, okay? So there are many different wavelengths in one spectrum of light, and if we change these wavelengths, it's just like having another light, okay, and all of them will be a blue light. So you see, our eyes see that, like, at least my eyes see that as green, and this is a blue light, okay? So it depends. There is a great group doing research specifically on that in US is Deborah Skin and Kenneth Wright, and they do this research about the same light but with different wavelengths and the impact on them, trying to find out the best one, okay?
so the blue light that is emitting from our smartphone that is harmful, right? But
Right.
the blue light from these glasses are not harmful.
No, they are too if I use in longer times. So, for example, if I wake up 3 in the morning and I want to sleep, but I put the glass on, it's warmed, okay? So I need to know what time should I use it. But I'm not saying for you to use the blue light from your device because it's different, okay? Those are made for treatment, and then there are pros and cons for that. For example, a patient with glaucoma could not use that. Okay, so before we use a device in our practice, we have to check everything to see if we can or cannot use.
But the like the some of us wear specs. So in the specs we have lens that is anti-glare lens to protect our eyes from the light which is emitting from the laptop. So if we are wearing those specs and then wearing this glass with the blue light, so is it safe like or it will prevent the effect of the blue light glasses?
I don't have the answer to your question. I don't know. I'll find out and let you know later. Good question, but I don't know. If you use both, I don't know. Thank you. Okay? You ready for the selfie? Okay. You just stay there. I'll try to put everyone here. Okay? So just smile. I'll put that in the group. Just one more thing. Do you want to say hello to Brazil? Yes. Okay, so I'm going to make a quick video. Speak little words in Portuguese. You won't understand anything, but I will translate, and then I'll get back to you all. Okay? So let's go. A gente está aqui em Nova Delhi, acabamos o curso agora, foi um sucesso. A gente conseguiu discutir muita coisa, trazer os fisioterapeutas da Índia. E eu estou honrada com essa participação. E, pessoal, eu quero dizer um oi para todos vocês, fisioterapeutas aí no Brasil. Say hello. And I think I'll be, again, speaking something for you in this afternoon. Okay? Thank you.
Obrigada, ma'am. A heartfelt thank you to Dr. Franz, ma'am, for this amazing session on circadian rhythm disorders. The blend of theory, diagnostic strategies, and clinical insights was seamlessly delivered and are deeply appreciated. Now it's time for lunch break. So after lunch, I request everybody to be here back by 2:30 so that we can proceed with the examination followed by the valedictory session. Thank you so much.